Hello, everyone. Welcome to today's Future Direction of Laboratory Medicine webinar called Doing More with Less, the Advantages of Optimizing Blood Collection Volumes for Laboratory Testing. I'm Bobby Prick, Division Chair for Clinical Microbiology at Mayo Clinic in Rochester, Minnesota. And we have several wonderful presenters today. Dr. Nicola Baumann and Darcy Block. They are both assistant professors of laboratory medicine and pathology in the Division of Clinical Core Laboratory Services at Mayo Clinic. Also, Tim Faber, Operations Administrator for the Division of Clinical Core Laboratory Services at Mayo Clinic, and Elaine Elliott, Senior Project Manager in the Department of Laboratory Medicine and Pathology at Mayo Clinic. So now I will turn things over to our presenters.
Okay, so I'll get started. From a learning objective standpoint, upon completion of today's webinar, participants should be able to describe a model and rationale for specimen collection improvements, defend continuous improvement as a strategic mindset for innovation, and design a data-driven model for collection volume process improvement. From an outline perspective, for the structure of today's discussion, I'll be providing a brief overview of our operations. Dr. Block will provide some information about our history, our current state, and some key details to consider. Dr. Baumann will be sharing information about our volumes reduction project, and then our team of presenters will be sharing our perspectives on our efforts, and Elaine will be wrapping up with our conclusions. So from a background perspective, I think it's important to kind of understand sort of our overall operations. Our central processing and central clinical laboratory teams support both the inpatient and outpatient practices at Mayo Clinic in Rochester. Our central processing team receives approximately 13,000 specimens daily. These samples are processed and distributed to about 100 different destinations within our main campus lab locations or across town at our remote laboratory testing site. Our central clinical laboratory is the core laboratory at Mayo Clinic and tests approximately 8,000 specimens each day. We're a highly automated laboratory performing automated chemistry, immunoassay, coagulation, and hematology testing. And we perform more than 6 million tests annually. And at this time, I'll turn it over to Dr. Block.
Thanks, Tim. So the specimen collection requirements are reliant on our analyzer requirements as well as our IT systems that are used to elicit the logic when it comes to size, number, and type of collection tubes that get used based on the test mix that's ordered. So I thought it would be helpful to kind of walk through some of that, kind of a short history of our laboratory systems and equipment in the laboratory. So in 2009, we implemented a vended laboratory information system from SCC Soft. Initially for collections, the phlebotomy staff used it for collections, and then a full deployment came in 2011 where all the testing laboratories began using that lab information system in Rochester. So then kind of interestingly, sandwiched between those times, the Central Clinical Lab implemented its first pre-analytic automation system, which was from Roche, called the Modular Pre-Analytics, often referred to as MPA. And this was, with that equipment, we were able to automate the pre-analytic processing and do some limited aliquoting in our laboratory. And then fast forward to 2019, we decommissioned that equipment and replaced it with the Roche Cobas connection module and replaced the MPA. We added additional functionality, being able to also add storage and retrieval, and I'll show a picture of that in a second. But in between 2011 and 2019, it's worth noting that there were a lot of test changes to our lab information system. From 2011 moving forward, we add hundreds of tests, new tests to our test catalog each year and make thousands of other modifications to existing tests. And so there's a large change management component to the lab information system as it exists today. So on the next slide, this is a schematic of our laboratory with the MPA systems. You can actually see, I'm not sure if I have a pointer or not, There's two teal rectangular boxes. Each of those is an MPA. We had a duplicate kind of mirrored testing systems. Each line had two sets of instruments attached to it so that we could accommodate both high and low testing volume periods of time based on like weekends or overnights, etc. And this system also used a system that relied on racks, which were somewhat restrictive in nature because they relied on having a 100 millimeter diameter tube, which equated for the serum gel separator tubes that we required for our testing, either the 5 milliliter or 8.5 milliliter collection tubes. And this is all important for the upcoming discussion that we're going to have. The MPA also didn't have a ton of capacity for making aliquots, so we do a lot of that and did a lot of that offline. On the next slide, we actually will see our current state, which in 2020, we implemented this Cobas connection module. It's a configuration that includes 3 pre-analytic modules comprised of, if you're familiar with the Roche terminology, it's their P612, P471, which essentially allows us to centrifuge, aliquot, and do sorting for tests that aren't on the system. And then there's a track that will take samples that are destined for chemistry and immunoassay testing to one of the 3 analytic lines that's comprised of the Cobas 701, 502 for chemistry, and 801 for the immunoassay. Overall, this accommodates about 100 analytes for testing. And then also connected to the system worth mentioning are those refrigeration modules at the top right corner. And then on the bottom left, we have the Sysmex automation line that's also connected to add efficiency to our testing system. And while we were, the process to install this actually took over 4 to 6 months because the old equipment was actually taking up residence in this space. And so it needed to systematically be moved out with the new equipment being moved in. So eventually we got to a point where we were able to fully connect the system and realize the efficiency savings that we anticipated receiving with this new equipment. So on the next slide, that was all really good. We were very excited. It was a major accomplishment. And of course, during that time, there was a little thing called the pandemic that was happening. So at a certain point, the dust had settled. And then in 2020, when our testing volumes kind of returned back to their normal baseline, a technologist in our laboratory made a very interesting observation. If you advance, yeah, there we go, there where they observed receiving multiple SST tubes collected from a single patient, but they noticed that the mix of tests were all for tests that were performed in our laboratory and thought that that was an unnecessary amount and wondered what could be going on that would cause this to happen. So one thing I want to point out is it's important to empower our teams to ask questions. And it's really our job as leaders to listen to what they have to say. In doing so, they'll hopefully not be inhibited to bring up issues in an ongoing way. And it could really matter to, when it comes to identifying errors and preventing harm to our patients. So the fostering the ability to and the environment to speak up is something we take very seriously. So on the next slide, that investigation was kind of like a tale of 2 cities. So on the top half of this graph, we have a whole list of tests that were ordered for this particular patient. We have a really good example of good specimen utilization where we have a single EDTA tube. It's going to 3 different testing areas of the lab. We're able to manage it through this shuffle essentially. And not lose them and still maintain good turnaround time. So that's a really great example of good utilization. However, in the Charles Dickens novel, the worst of times was yet to be observed, and that was in the chemistry testing and some of the combining logic that seemed to be going awry for for this collection. So it turned out that the technologist was absolutely right. We somehow had gotten 5 SST tubes for what we thought was testing that could, it's quite a list of tests, but probably could be accommodated by a single, at least 5 milliliter SST tube. So we definitely thought that this was unexpected and an opportunity ripe for improvement. On the next slide, I'm going to take a small detour. Someone submitted a question about rainbow draws, and in time to add a little bit of content for that. So I'm just going to talk a little bit about this controversial practice. And if you aren't familiar with rainbow draws, it's the practice of drawing one of each type of tube for the purpose of being able to accommodate add-on requests or those orders that are placed after blood is drawn. And the idea is to either save the patient an additional poke or potentially do additional testing at that point in time as the patient condition may be changing. On the next bullet, this group of investigators sent out a survey of laboratories and a fair number responded, and it was very interesting. Almost 60% of labs accommodate a rainbow draw collection of some variety. Usually these are only limited or usually only performed in the emergency department. And some hospitals will limit it even further to certain patient populations where they want to avoid or it's not easy to get additional blood if needed. However, the reality is that, and this has been reported in multiple publications, fewer than 10% of these just-in-case samples are ever actually used and ultimately end up getting disposed of. So in the impact essentially is we can affect patients by causing or contributing to iatrogenic anemia or blood draws. It's excess cost because a lot of stuff is getting thrown away, excess effort, accommodating these additional workflows or alternate workflows, even just getting a label for a sample without any orders on it is, you have to kind of trick the system to do that. So I would boldly recommend discontinuing this practice permanently. We're very fortunate in Rochester. As far as I'm aware, we've never had this rainbow draw practice in place. And so fortunately, we didn't ever have to stop doing it here, but we manage very well without it. So that's my detour. So just kind of to recap where we are today, we recognize we have new instruments, automation updates that went into place. We had some unexpected downstream effects and upstream effects. So one, the lab staff observed more tubes being collected than needed. We also had observed our refrigerators were filling sooner than expected. So these seem to be related in some way. And so this was definitely a good opportunity to reassess our collection volumes for those commonly ordered tests. So our objective was to evaluate whether updating the blood collection volume, so kind of going into the test configuration in our LIS for these chemistry and immunoassay tests, if making those modifications could reduce the volume of blood collected and the number of tubes that we're using from our inventory. So the methods that we use to go about doing this, so we did consider our full test menu for chemistry and immunoassay. As I mentioned, we have a lot of LIS test codes to accommodate, the 100 analytes that we are interested in. So some of which include panel tests, some other reflexes and cascades, etc. And then just the full test mix that we have both on the Roche system as well as the offline immunoassay testing. We wanted to be able to make the best use of a serum tube within the 4 walls of our laboratory was essentially the goal. In order to do that, just back a little bit, Elaine, we evaluated the configuration in the LIS. So there are a number of parameters for that, and we'll go into more of that detail for volume requested, and then the logic for how they combine into the tubes also needed to be reviewed. So we, in order to evaluate the success of this project, we looked at a single day of orders. We wanted like as real world as it could be. So we looked at 128 patients from physician ordered lab testing on a day. We calculated the volume of blood collected by counting up all the different tubes that were requested and then multiplying that by the volume of the tube so that we could add up the total volume per patient. And then also we documented the number of tubes per patient. And then we compared those metrics at baseline and then once these configuration changes went into place. So on the next slide, I'll talk a little bit about the LIS configuration itself when it comes to blood volume. And I think it's important to acknowledge that every LIS is probably different and uses different nomenclature, but I think the concepts are probably somewhat universal. So for each test, we configure a dead volume or that volume of sample that's needed so the instrument can accurately aspirate the sample from a tube without manipulation. So in our configuration with the MPA in the table on the left-hand side, we had configured the dead volume. We kind of inflated it because again, our system couldn't accommodate smaller tubes than the 5 milliliter tube. So we adjusted that to 3.51. So we would always get at least one 5 mil SST tube. We also had our analytic volume kind of set across the board with a single volume of 0.1 milliliters, which kind of accommodated most tests. But what we noticed in our future configuration and what we adjusted was not only that we could now require a dead volume that was more accurate. So we adjusted that down by almost 2 milliliters to over 2 milliliters, 1.25. And then we went to the package inserts and looked at what the manufacturer said the analytic volume was, and we used those volumes. So it was very evidence-based decision making. We also know that we sometimes need to do more than one single test. So we knew we needed to accommodate add-on requests and maybe the need for retesting if QC happened to fail. So we took that analytic volume and we multiplied it times 4. And then when it comes to the calculation and the logic of we request a volume of blood be collected by the phlebotomist, but then we're actually yielding serum or plasma, which you have to subtract the volume of the cells. We didn't really have a documented equation prior to our review. So we came up with, and we made kind of a conservative assumption of a normal hematocrit of 40%. So when we calculated our serum plasma volumes that was needed for testing, then we multiplied it by 2.5. And I just put a side note in here about micro collections, especially on neonates. Their hematocrit is normally 60%. So I would recommend making adjustments if you're making considerations for neonatal sample collections. So from all of this, it's kind of complicated and something we did not think would be easy to spread and have everyone consistently applying. So Elaine, on the next slide, we actually developed a calculator. And the calculator just really helped to make it more user-friendly. And so we rolled this out to any of the test builders where they're able to select, it's basically just kind of a glorified Excel spreadsheet, but it has some drop-down questions and clear definitions so that they can consistently apply the rules and the calculations across whatever test they might be manipulating. And it calculates it and gives them, basically just fills out the fields that they need for their test build. And it also calculates what the volumes are that we request in our test catalog for our Mayo Clinic laboratory customers as well. So with that, I'll turn it over to Dr. Bauman, who will share the exciting results of these updates.
Great. Thank you so much, Dr. Block. So I do get the privilege of sharing the data, which is really the best part. So let's just re-baseline ourselves to where we are right now with this Clinical Core Laboratory Services blood test volume change project. So in the Central Clinical Lab, we identified 111 tests that needed to be updated according to the calculation that Dr. Block just described. And instead of applying this, just a uniform amount across all the tests like had been done previously, we went to each package insert, we looked up the analytical volume, the dead volume, and these were test-specific calculations for each test. So all of that information was updated. The collection volumes were put into Soft Lab using the calculator that Dr. Block just described. And we expected that there should be a change from predominantly 5 mil and 8.5 mil tubes being collected to more 3.5 mil SSTs. And we estimated it should be about a 30% decrease. So, and the reason for that was, remember, our MPA could not accommodate the 3.5 mil SST tubes, but our new system could. So we knew that that change would be happening. And this is where you have to start thinking of unintended consequences and all of the stakeholders that are peripherally involved and even directly involved with the lab. So we maintained a close partnership with supply chain because previously, at least for our central clinical lab, 3.5 mil tubes were not part of the workflow. So we had to make sure we had those tubes. And many of you recall at the same time that this was going on, there were also supply chain issues. So we knew with blood collection tubes. So we knew that any project that was trying to reduce the number of blood collection tubes was a good thing because there were some really critical times during those supply chain shortages that have luckily largely resolved. We also really needed to collaborate with phlebotomy. And that's because they are providing the input for our system and we needed full tubes. So if now with our current calculator, we are calculating the minimum amount of volume really required to get testing done, we need to make sure that all of that blood is actually collected. And you can imagine how behavior changes over time. So if a phlebotomist sees that, like the example Dr. Block gave, that a patient needs 25 tubes collected, human nature is going to possibly make them collect less than full tubes because they're just thinking about the sheer number of tubes. So we had a very intentional educational program to help phlebotomy understand these changes and the fact that full tubes are required. And I'm going to do just a quick little sideline here about full tubes because I know there was a question submitted about this. So filling collection tubes full of blood is just a best practice across the board. Even for an SST tube where there's no additive, there's no anticoagulant, there are studies, and there are many studies in the literature. I found one that talked about underfilled tubes having a 261% increase in the hemolysis index if the tube was underfilled. And presumably that's from the jarring that would happen through transport through a pneumatic tube. That's one of the contributors or whatever transport system is used. But even lithium heparin tubes, if they are underfilled, there are many studies talking about changes in lab parameters. LD can increase by up to 30%, potassium up to 25%. So again, full tubes, best practice. It's how these tubes were designed to be used. You're going to reduce hemolysis. We know for coag's the one that's obvious to us because we reject them when they're less than 90% full. But even potassium EDTA, if those collection tubes are underfilled, you will see significant differences in CBC parameters. And again, there are several papers in the literature reporting this. So having a policy in your lab for how full tubes must be is, I think, really a good practice and something that we can discuss further afterwards if people are interested. So that's my sideline. We, of course, expected the number of SST tubes to decrease by applying these new equations and calculators. And we went live with these test changes on February 20th, 2023, just about a year ago. Next slide. So let's get into the data. Dr. Block talked about these 128 unique patient orders. This was really our simulated data set. These were real patient orders. reflecting what our practice actually orders on our patient population. But it was a unique example where we could take 128 orders and assess them pre-change and post-change by simulating them through these changes. So looking at these, and the next few slides will all focus on these patient orders. Oh, sorry, go back, please. So if we look at the total volume of blood collected, pre-change, it was about 2,065 mils. After using the calculator, we had a 59% decrease, and it went down to 851 mils for the same number of tests. Next slide. The total number of tubes also decreased by 52%. So it went from 414 tubes down to 197 tubes. So we're seeing 59% decrease in total volume of blood and 52% decrease in the number of tubes. Next slide. We also wanted to look at efficiency parameters. So for example, how many tubes were being collected per order. And here you can see that the median number of tubes per order decreased by 2. So it went from roughly 3.5 per order down to 1.5 per order. Next slide. And then on a similar efficiency vein, the median number of tests per tube increased by over 10. And of course, by eliminating that 3.51 dead volume, that had a significant impact. But pre-change, the median was about 5, and it was over 15 post-change. So we had very solid data that these changes would have an impact. Next slide. These data are real-life snapshots. We took a period of time pre-change, a period of time post-change, and these were short periods of time, but we tried to make them as comparable as possible. And the blood volume collected, on the left side of the slide is the actual raw data, but then we use those data to look at how many fewer tubes were used, so that would be an impact, and how much less blood was collected as a second impact. So if we use the raw data on the left, we calculated that we should be using roughly 2,900 fewer tubes per week. That's a 41% decrease. And if you roll that to an annual basis, it's a reduction of over 150,000 tubes per year. So this is a significant decrease. And I think, again, looking at it through the patient lens and actually collecting less blood volume, this was also staggering. So it was 20,600 fewer mils per week. That's a 59% decrease. And if you look at that at an annual basis, it was over 1,000 liters per year, or 283 gallons. So I had a hard time conceptualizing what 283 gallons of blood is. The average human body has about 1.3 gallons of blood. So that's the human bodies. And we were collecting 283 gallons per year. So that's pretty significant. There's a cost savings associated with this. Now, tubes are pennies per tube. So on an annual basis, in our books, this came out to, roughly $24,000 annual savings. In a total lab budget, that's possibly not significant. But one of the other issues and the unintended consequences of having all of these tubes is that, as Dr. Block said, our refrigerators were filling up before they were supposed to. We were having to discard samples prior to our 7-day retention period, or if not discard them, start storing them somewhere else. But also the capacity of our system was really being taxed because we had this increased number of tubes just on the system. So I think of this as just traffic on the road, and we decreased the number of cars by 41%. And this was really noticeable to the techs at the bench. So we increased capacity without having to spend a dime on new automation, new equipment, new analyzers. Next slide, please. And you always, with any good quality improvement project, we want to have counterbalance measures. So some of the things we thought that could be unintended consequences would be that because we were really requesting the exact volume that we needed, would there be an increase in samples that we had to cancel or recollect because they were quantity not sufficient, or QNS in our lab terminology? And we monitored that for several months after the go live. There was no change to recollection rates due to quantity not sufficient. The other thing we were concerned about is that we seemed to have this extra blood that was not intentional, but we had extra blood and we were able to complete add-ons. And add-ons are a convenience that our practice loves. When I tell them I'm one of the co-directors of the Central Clinical Lab, they say, well, you're the lab that stores the extra serum for add-ons. So this is a big perk to our providers, as I'm sure it is to all of you in your institutions. And we also had no change to being able to complete add-on orders. And so that was telling us that that was really validating our calculator that we had accounted for enough blood. So at this time, next slide, please. I will hand it over back to Tim, and each of us wear hats within our lab and our institution, and we wanted to share a bit of our own perspective. So I'll hand it back to Tim Faber.
Thanks, Dr. Bauman. I think, as I look at this, setting this up as a program was really fundamental in allowing for some success with the project that we're talking about, but also the other ideas. So, as an administrator for central processing and the clinical core lab team, I think a few things I found really beneficial. So as an overall leadership team, we've been focusing on creating an operational excellence structure with a real focus on generating improvement ideas from all of our team members. And the idea being that they can be brought forward for consideration and implementation. I think having this set up as a program provided a few things that are fairly unique that allowed the ideas to come forward through a variety of channels. And we did listening sessions and some focused discussions. We also have some management for daily improvement idea boards where these sorts of ideas from the staff and from our colleagues across the labs can be vetted. And with the way that we were set up with this program is that we had a consistent team, both from a leadership, a stakeholder standpoint, but also as kind of a core team. And when an idea was shared, our team was positioned to do an initial analysis to quantify the benefits and maybe the projected work involved in the improvement. And I think that low barrier threshold was really impactful and important for our team to be successful in getting some of these broader ideas that we're talking about today, but also some subsequent ideas that were shared as well. I think, as an administrator, to have a structure that didn't require an individual project proposal or project charter being submitted, that we were able to dialogue and work on these ideas with the operational teams was really impactful. And what we found was for this first initiative and some of our subsequent initiatives, that when an idea or a process moves beyond one lab, that becomes more challenging. So having a consistent team to work on that and partner, we were able to look for those ideas where there was improved patient experience, better stewardship of resources, expanded and improved efficiency or improved quality, as we were able to outline earlier. So from my perspective, that was fundamentally important and one that we've been very fortunate to continue. So, Dr. Bauman?
So the other role that I serve in the Department of Lab Medicine and Pathology at the Mayo Clinic is that of Vice Chair of Quality. So being a lab director, I think all of us focus on quality, but it's been a passion of mine for my entire career. So I wanted to put on my Vice Chair of Quality hat and look at these projects, and as Tim said, this program, and just a few kind of nuggets from a quality perspective. And Dr. Block mentioned this previously. When people speak up, listen. And this is about, it's about a culture, it's about an environment, but Dr. Block and I have really fostered an environment where our staff are comfortable speaking up about problems because they know we will listen. And this all started because lab staff communicated a concern, they made an observation, and they brought it directly to us. And then what we did was we asked questions and we were curious about what they were seeing. And we didn't make excuses for it. We were curious and wanted to be informed. The second is be data driven. There is no replacement for data. So in this situation, data confirmed the concern. So it was not just an observation, but the data confirmed it. Data identified the issue, and data verified our solution and verified that we had identified the correct root cause and we were fixing it. Use your quality improvement methods. So we frequently use fishbone diagrams, we use root cause analysis. These are not new tools, but we use them and we use them to solve system issues. In line with that is we're able then to educate our teams on these quality improvement methods. And then you get into, instead of a vicious cycle, a really good cycle, a cycle where people think, I'm going to speak up, leadership is going to listen, they're going to use data to identify the problem, and after the solution is identified, to verify that it works. And the system will slowly but incrementally get better. And then anyone who does anything in quality knows that you can't improve what you don't measure. And so measuring is so important. I got to share the data from our pre and post intervention. But don't make sure that you don't just look at the data that you want to see. We also had to think about unintended consequences. And I think throughout my career in quality, that has been something, it's not as easy to do as just measuring pre and post, but always think about who else might be impacted, what else might be impacted, and make sure you measure that as well. I'll turn it over to Dr. Block.
Yeah, so similarly, Dr. Bauman is the vice chair of quality, and I also am fortunate enough, I serve as the vice chair of informatics in our department, which makes me, I wouldn't call myself an expert, but I'm well versed in LIS and other systems. So my pearls that I would just share today from an informatics perspective is really that initial system design. You know, we had the new system an opportunity to devise our workflows, the logic, and I think it's my take-home messages for that is to really make good use of the system, trust it to do what it's supposed to do, verify that it's doing what it's supposed to do, obviously, but we really want to take advantage of that functionality. And then think of it from the big picture again. Many of these pearls coincide with the same ones from quality, but we really want to utilize that patient perspective. You know, it's easy to think, you know, we're a laboratory that is spread across many areas, and we all want our own tube, and we all want to make sure we have plenty to do the testing. And if we add all of that up, it gets to be more than we should be taking from a patient. So we really try to make the most efficient use of a sample as possible. And again, making sure there aren't unintended consequences down the way. And then the thing that I think I really learned from this project, and you know, once our system, it was implemented in 2011, some portions had been updated and changed and modified. Some maybe hadn't changed at all since 2011. So really you know, it made us go back and ask, what are the procedures and processes that we've instructed our builders to use in maintaining that original system design with the patient perspective, and try and maintain that throughout all of our change processes. It was definitely a learning experience, and you know, we may have undergone more change than your average laboratory as we've expanded our footprint out at Superior Drive. So I think, and every time we realize now instruments aren't always a reason to rethink the LIS, but there is definitely a link. So having an open mind to, you know, an observation such as what was brought to us with this, you know, you wouldn't really think an instrument would have much bearing on the sample being collected because we're not really connected. But at the end of the day, we found that requirement for that larger tube was actually a large part of the improvement to be made in that system. So I'll hand it to Elaine, because none of this would have been possible without the help and administrative support of a project manager.
Thank you, Dr. Block. So greetings, everybody. In my role as a project manager, I've been very fortunate to partner with professionals like yourselves with expertise from different backgrounds and all come together during this defined moment of time to achieve a project goal. And I'm strongly motivated by the team dynamic. In most cases, I see my colleagues are very busy with their day-to-day roles, whether in operations or leaders. They often don't have the opportunity or the time to focus specifically on a project. And so in my view, that's really where a project manager and or a business system analyst can be beneficial to a project. In my role in the clinical core lab project, I'll just say that I found that helping to foster a successful outcome here meant really often behind the scenes, but helping the team to navigate through many different processes. And it also involved collaboration across many different groups. And so that's really the power, I think, of a project when it's run ideally. It comes together, the many moving parts come together in a way for success. And so I wanted to build off of a couple of the examples that were raised earlier by Dr. Block and Dr. Bauman. But when doing more with less, or in this case, running tests with less blood sample, there's less margin for error in the testing. And so early on, we identified a potential risk, as Dr. Bauman mentioned, that there could be cases where a patient would be asked to return for a redraw if there was insufficient sample to complete a test. So as she mentioned, but to build on this, to mitigate the risk, we worked closely with our clinical care leaders to inform them of the risks. Also worked closely with our partners in phlebotomy. And we were, as mentioned, very intentional about change management. And so that included really educating, building awareness of the change, importantly, conveying the benefits that would outweigh the risks, and to helping to build an understanding of how the individual's role could really impact the change and the success of a project. So in this case, helping our phlebotomist team to understand that their role in collecting the full tubes was really critical to the success of this project. And of course, having a solid set of the validated testing data and the theoretical benefit calculations really helped us to be able to quantify the benefits and the risks more effectively in those communications, so that teams could really grasp the change that we were trying to pursue. As Dr. Bauman mentioned, fortunately, we found no negative impacts, only gallons of blood saved. However, had we not used a data-driven model, we would be basing our progress on theory. So really, the accuracy of the data is very important in being able to demonstrate the project's success. One other brief example that Dr. Bauman also alluded to was a change management process between our lab service teams and our partners in supply chain operations. Again, with the change in the size of the tube being used, we wanted to ensure they had adequate stock on hand. Our goal in communicating was really to empower these teams to be comfortable and prepared for a change to a smaller tube, and to allow them ample time to plan for a potential shift in ordering trends. And so I'm really calling out the power of collaboration, coordination, and communication. Of course, there are a lot of other tools and methodologies in project management, but for me, I wanted to call out the importance of listening and communication really can't be overstated in helping to build a level of comfort with change, of awareness, identifying, again, those key stakeholders, allowing them the opportunity to raise questions in advance, to have input into a process, to know what's coming, what to expect, so that they can plan all of these are very simple steps, but very important to a successful project outcome. And so in closure, some of the key takeaway messages that the team is bringing forward are really related to operational excellence and data-driven models. So again, to recap what's already been said, having an operational excellence mindset really frees and empowers our teams to be able to bring good questions forward, to stay curious, to stay restless with a process. And as mentioned, it's a culture that seeks continuous improvement. So whether the goals are to do more with less, or to improve productivity, or improve the patient experience, continuous improvement really connects us all in a shared goal of excellence. So the goal is excellence. And that's where the use of data-driven models comes into play, because it's really key to bring logic and definition to the operational excellence measures. It holds us accountable to the goals. It helps us to monitor the changes, and then importantly, helps us to measure the resulting benefit of the changes of the work that we're driving towards. So one of the goals today that we had was to really spark and ignite your bright ideas. And so in closing, we encourage teams to continue to stay curious about your own systems, about your own processes, to raise great questions, find new and better ways, if possible, find partners and collaborators who can help you to operationalize them. As always, those who are closest to a process are so important to finding and raising those intelligent ideas and questions. And your support is so important to patients. So any questions that you have in a minute will be more than welcome. But I quickly wanted to take a moment to thank Dr. Bauman, Dr. Block, and Tim Faber. Also, we had an executive sponsor team, Dr. Binnicker, Dr. Karen, and Addie Singh, for their important leadership in fostering a culture of operational excellence.
Well, I'd love to thank the team for that outstanding presentation and congratulate you on your excellent results. At this time, we would like to take any questions that you, our listeners, may have. Remember, you may submit your questions through the Q&A, question and answer icon in Zoom. Now, I don't see any questions yet, so I'll ask the first question while we're waiting. So Dr. Bauman, Dr. Block, and Tim, we have a dyad model here at Mayo Clinic where our scientific and physician leaders partner with our administrators, and that dyad is so important to get things done. Do you want to touch a little bit about how that partnership was so important in this particular issue? And I know you also had an outstanding project manager, but just starting perhaps with the top from the divisional leadership with that dyad.
Well, I'm not on mute, so I'll offer a few thoughts and then turn it over to Doctors Block and Bauman. With that dyad, structure, I think there's some things that happen sort of organically where there's a little bit of clarity on sort of the administrative tasks and aligning the team and making sure that there's good support. I think also making sure that the reporting relationships and the ideas are flowing so that we've got a good structure around how our staff are able to bring things forward for consideration to our lab directors. And then also making sure that as these ideas started to come together, that we had a structure that supported that. So whether it was working with the staff that were bringing the idea up, our LIS coordinators that needed to help with the system change, engineers and analysts to help project what this would take, thinking about those other considerations and potential unintended consequences. I think making sure that structure is there to support, then allowing our lab directors to really focus on the science and the best practices of the laboratory. So that's where I would start. Yeah, thank you, Tim. Dr. Block, Dr. Bauman, anything to add?
I agree with everything Tim had said. And, as a lab director, it's relatively easy. And I think I'm probably speaking the language of many. It's relatively easy to change something within your four walls. but that coordination when we needed, and you know, we actually made this into a departmental initiative with the calculator being shared with other labs. But this project had so many stakeholders, and so Tim's partnership to help align the administrative and medical director's support of these other areas, I don't think we could have done it without that. And, you know, Elaine was just busy, constantly gathering more gems and golden nuggets of information. And also, as she was talking to people outside of our lab, outside of our division, she was also collecting more ideas. And I think that's where if it just would have been Dr. Block and I doing this, we probably could have changed our own test volumes and done, you know, a small project, small process improvement, but we wouldn't have been able to see the magnitude that we saw because there were so many people outside of our area that were getting pulled in because of Elaine's leadership and Tim's leadership and growing ideas. I mean, ideas were being grown and fostered, and you know, we had these tentacles going off into other things starting. So I think that collaboration, it's great for getting things done. It's great for making connections, but it's also great for fostering new quality improvement ideas. And we now have a program that is, you know, starting on new initiatives and continuing these improvements.
Thank you, Dr. Bauman. That's a great answer. We now have a number of specific questions coming in that relate to your talk, so I'll just dive right into those. Starting with the first one. Great talk. I arrived a little late, so you may have addressed my question early in the talk. Did you quantify the amount of refrigerator space saved?
Not directly, but what we knew what our weekly volume was estimated to be. And we knew that the system that we purchased with 2 of the refrigerated units, the P701s, we knew that should have easily handled 7 days of volume. That's how long we keep our residual patient samples. So the fact that it wasn't, it was, you know, maxing out at day 5, day 6, that was a problem. What we know, we haven't actually calculated, you know, number of racks available or extra capacity, but we are able to keep samples for our 7 days. We no longer are maxing out capacity. So not a super quantitative answer, but qualitative, I guess.
Sure, that makes sense. We have another question. Do you have some references for clinical impact for underfilled tubes that you could share? And perhaps that's something we could share afterwards because it sounds like you had a number of references.
Yes, I did find several. Is there a forum that we can post information afterwards? I'd be happy to share.
We'll look into that. I'm sure there's a way we could do that, perhaps when we post the recording.
Great.
Okay, another question we can answer now. How was the tube monitored between test methods? Was serum aliquoted? I'm not sure I understand that question. Does that make sense to either of you?
I think so just generically, I'm not sure I totally understand the what the person is asking, but you know, we in general the serum testing that we talked about today is mostly done all on one system. For offline testing, we would make an aliquot and, you know, have to transport it over to that workstation. We also make a lot of aliquots for laboratories outside of the central clinical lab, and all of that is managed with sample tracking in our LIS. Same with, you know, like my example with the EDTA tube. Once it completes testing on one workstation, it gets tracked to another one. And so we use a lot of barcode scanning and tracking in our LIS to, you know, kind of maintain samples and their whereabouts until testing is completed.
Thank you, Dr. Black. Another question, how would you calculate the required sample volume for pediatric microtubes?
Dr. Block, do you want to take this one?
I'll take it. It's actually something we're currently discussing. We have kind of a we do not currently use our the combining logic and test volumes that we talked about today. Those are optimized for adults. Obviously, pediatric tubes they're much smaller volume. They have a different hematocrit. But we basically have kind of just a separate SOP that our phlebotomists use, and we've tried to make it as simple as possible, where we tell them if it's X number of serum or plasma, we actually collect all plasma for the neonates. If it's X number of tests, we need one microtainer. If it's more than that number of tests, then we say, collect a larger volume, 2 microtainers or a 1 milliliter in a 3 milliliter tube, that sort of thing. So we try to maintain the minimum that's needed for testing, but that would not leave us short to complete all of it. But it's tricky. If anybody has it figured out, contact me.
Thanks, Dr. Block. I think we have time for one more question. So I'll ask one that's a real nice change management question. So since a change like what you undertook impacts how work is performed, how did you communicate and get buy-in with your laboratory technologists?
Good.
They were the ones that brought the question forth or the observation. So I'm assuming that they were approving this, but did you receive any pushback, any concerns?
No, so thankfully, from an in-lab perspective, this was an entirely positive change. It was fewer tubes, less traffic on the system. The refrigerators weren't filling up. So very positive from the lab technologist perspective. But we still were very organized, and I'll let Elaine chime in. We were very organized in our change management and providing updates, presenting data, and then as we mentioned, the other stakeholders. So it was very important for phlebotomy to buy into filling full tubes and understanding why. I don't know, Tim or Elaine, if either of you have a golden nugget for that one.
I would just add, Dr. Bauman, that our partners in phlebotomy education and lab service education were also just wonderful in helping us navigate that process. And so having kind of an open forum, the ability to communicate, to paint the picture of what benefit they would see for the patient was very important. And then also really helped to understand the why this was happening, and then their specific individual role and how it would, how they could help with the success. I think, everyone that we worked with is so well-intentioned, and really looking to do the best for the patient. We really, as Dr. Bauman said, didn't have much pushback. Just really the communication piece was huge, and that team really made that process easy.
The only other thing I'd offer is that we were very intentional about bringing them in early. So this wasn't something they were told they had to do in, alignment with the system change. There was a real intention of bringing our stakeholders in before the change, so that why and the patient impact was clearly understood. And I think that was critical.
Yeah, that's always so helpful. Well, we're now at the top of the hour, so I'd like to thank our participants for joining us today for our Future Direction of Laboratory Medicine webinar. I'd like to thank the presenters for their outstanding presentation. For those of you that are still listening, if your question was not answered during today's session, or if you have additional questions, please include them in your evaluation. You can reference the link in the chat to access the evaluation now. And as a reminder, laboratory credit is extended for this program. So upon finalizing your evaluation, you'll have the option to claim credit and print your certificate.